on your Moodle page, and you'll also be able to access it later on through a link on YouTube. So this whole unit, it spans over three um, sessions. So there's learning outcome 1, 2, and 3. So this will happen every Saturday and Sunday. So if I open up my calendar, so it's the 31st that we are doing this session today. So you have LO1, learning outcome 1, that we will cover today. Learning outcome 2 will be covered tomorrow, which is the first, and it's a Sunday. Learning outcome 3 will be covered on the 7th of June, okay, which will be a Saturday. So those will be our 3 learning outcomes that we will complete. And the fourth bit is your assignment discussion, which will happen on the 8th of June, which is a Sunday. So what we do, just keep in mind, at UKversity, when we're done with our assignment discussion, this gives you 2 weeks to complete your assignment and submit it. So according to the 8th, if we complete our assignment discussion on the 8th, God willing, 8th of June, you have 2 weeks, which means that you will be submitting, you're expected to submit your assignment on the 22nd. Okay, this is just for this unit. I'm not talking about the other units. You may be submitting multiple assignments together. I'm not mentioning those units. Okay, I am strictly just talking about this unit. Okay, so the 22nd of June is your deadline for the assignment to be submitted. A bit about what this unit covers. So as we know, I hope you can see this screen. So I'll just share the learning outcomes with you right now. So the learning outcomes for this session, for these 3 learning out. So you have 3 sessions, which means you have 3 learning outcomes. I hope you can see my screen, everyone. So the first learning outcome, which we will discuss today, is understanding the factors that influence health. So here we are going to explain the key social issues, okay, in contemporary society that have an impact on health. Okay, so here you will explain social issues, because we are talking about social and community welfare provision. And then you will go on to discuss how these issues affect health and well-being. So once we've talked about what contemporary, what issues there are, what social issues do we have in the society, then and how are they impacting health, we will also talk about their impact on well-being. Okay, this is our learning outcome, by the way, for today. So next, tomorrow, the second learning outcome will have you to understand the development of social and community welfare provision. Okay, first you were talking, today we are talking about the factors influencing health, and tomorrow we will talk about the development of social and community welfare provision. And here in the development, like in human body development, we talk about milestones, like what happens on the first year, what happens in the second year, what happens in the third year, what can you expect. So here we will talk about the key milestones in the advancement of social and community welfare provision. The, and the second bit in this discussion will be to compare and contrast current health service provision with preceding healthcare services. Okay, we'll do a comparison. And then the third learning outcome, the last learning outcome, which will be discussed next Saturday, is to understand the values adhered to in service provision. So here you are discussing the core values that underpin social and healthcare service delivery, and you would identify and discuss the ethics that underpin social healthcare service delivery. That's it. These are the 3 learning outcomes that we will be covering in the 3 days of the weekend. Okay, so I'll stop sharing. Any questions there, please feel free to text if you don't feel comfortable speaking. If you can't speak, it's totally understandable. Okay, that is why we have these online sessions, just to support you in every way that we can. So we'll talk about the first learning outcome, which is just a minute. I'll start sharing my screen. Please let me know once it's visible to you. Um, okay. Yeah, I have it here. Okay. So this is the first learning outcome. So here we are understanding the factors uh, that are there influencing health. Okay, so we're talking about all those factors that you think can influence health. Um, Anyone's got any idea what could um, these factors be that influence health? Any social factors that influence health? Anyone? Any student? Anyone? No? Okay. Um if you're aware of them, I would appreciate if you could text or write it in the chat box. I don't mind that. Okay, so when we talk about social factors that influence health, you could have in the social factors we have employment, we have education, we have socioeconomic statuses, we have things that play where you live, where you dwell. So all of those are um, have to do with your influence health in one way or the other. So we'll talk about a bit of the key terminologies. This is what we discuss in every session. So what is social and community welfare provision, or social and community welfare? So a social welfare system, it offers assistance to individuals and families that are in need. And with such programs such as healthcare assistance, so you may have food stamps, you may have unemployment compensation, just as like for employment support, you may have the job seekers allowance, for instance. Lesser known parts of a social welfare system include disaster relief and educational assistance. This happens only when you need it. So when a disaster happens, for instance, there's an earthquake, you get some disaster relief. There's an you're doing a degree, for instance, and you need educational assistance. You won't be doing that degree all your life. You'll do it just for once, okay? Or twice, whatever the case may be. However, you have these as constant, like continuous services like assistance, you have food stamps, unemployment compensation for as long as you're unemployed, for instance. So in England, because it is a welfare state, um, so it's the social care is defined as the provision of social work. You have personal care, you have protection or social support services to children or adults in need or at risk, or adults with needs that arise from illness, disability, old age, or poverty. And what does social welfare mean in the UK? So, social welfare law, it's the term that is used in the UK to describe those areas of civil law in which people on low incomes, who are typically disadvantaged, are prone to experience difficulties. Okay, internationally, the term poverty law is used. Okay, in the UK, we use it as social welfare law. And what are the main objectives of this law of social welfare? So, social welfare aims at providing services to those who are underprivileged, who don't have the privilege, who don't have basic necessities for living, to support them, and various forms of social insurance against poverty, unemployment, disability, and old age. So, this is a video that you can have a look at. What this video is about, it tells you about the community centered approaches. Okay, so I'll talk a bit about this video. Okay, so what does this video have in it? So when we talk about community health services, and especially those that are community centered, what do we have in them? So in community centeredness, um, we have community health services that cover a wide range of services, and they provide care for people from the time they are born to the end of their life. Okay. And community health teams, they play a vital role in supporting people with complex health and care needs to live independently in their own home for as long as possible. Community health services include, they can have more, you can have more examples also, but some of them are urgent community response, including 2-hour rapid crisis response services. You have district nursing, you have child health services, community occupational therapy, you have wheelchair services, and health visiting. Okay, so within the UK, within Britain, what are the examples of social welfare? So, welfare benefits in the UK, they include 5 separate groups of services. So, they are cash benefits, healthcare, education, housing, and personal social services. Most widely, what is used in the UK are cash benefits, and these make up about 10% of the gross domestic product within the country. Okay, so the category of cash benefits, it can be broken down into 3 subcategories. So you have cash benefits as the umbrella term. Within this, you have 3 different categories. So you have national insurance, you have means tested, and you have non-contributory benefits. So the national insurance system makes up the lion's share of the social expenditure in the UK, while the non-contributory benefits, they rank second and means test benefits as the last. A problem in the UK have been the low benefit levels. For instance, pension benefits are less than half of a person's active salary. Okay, so it's very less, and you can't really work for the rest of your life. You have to have, obviously, you are retired, and then that is when your pension works, but that is very less, and that can't support you as it was supporting you during your active salary stage. Then coming towards healthcare, so it's the second major part of UK's welfare system. The first was cash benefits. Second is healthcare system. So it is organized through the NHS, the National Health Services, and it's financed by our taxes, the people who earn. So the system is popular and it's relatively cost effective by standards of other countries. As it is universal, it covers the entire population and it is virtually free to people. Priority is given to those who are in crucial need of medical assistance. Okay. Yet those who need non-emergency medical services must wait sometimes up to 1 or 2 years. Such as if you want an MRI scan to happen, a CT scan to happen, you'll have to wait for considerable um, time for that to happen. Now, education. So we had talked about cash benefits, we have talked about healthcare. Now we are talking about education. So education is also an important component. So what do you do here? What is meant when we have education? So education, we know that it is free for almost all children within the UK. So what happens? So all those children who are school aged through the years 5 to 16, they have access to free education. Yet as they reach the age of 16, fewer lower class children move on to further their education and move instead directly into workforce because they don't have the money or the resources to be educated, and that is when they resort to instead of education, they resort to working instead, and they find working better than gaining an education, which is very unfortunate. Um, so the system of higher education does not reflect a class bias. The responsibility of the British education system lies within the central government, the local government, and other professional interests. So all these three, the central government, the local government, and the professional interests, they have a part in public school system. Okay. The central government, it provides for a legislative framework. So there's a legislation, a law for the schools, while the local governments generally focus on organization of schools. Professional interests tend to influence the curriculum and testing procedures also. Okay, so you might have the Ofsted, you might have other testing systems that are there that influence curriculum and different testing procedures as well. So we talked about cash benefits, we talked about healthcare, we talked about education, and now is public housing. So it comprises of council-owned rented housing. The owner occupation housing, however, is the most popular in the UK, mostly because it is based on a taxation subsidy system. In fact, three-fourths of the working class homeowners in the UK live in subdwellings. Social housing is controlled by the local government and usually provided by applying a means test. Okay, so everyone will not have access to it. It will just be some people who need it the most. As in most other Western countries, the aging of the population is one of the biggest challenges for a welfare state in the UK, because the welfare state has to deal with all of these social services. However, aging of the population is one very big aspect that they have to deal with. The government in the UK is faced with a growing elderly population. Okay, just as I said, I met a man who was 90 years old just yesterday. He was fitter than what I am right now at 40, but um, he was brilliant. Yeah, that's how we all want to see ourselves. So yeah, if you think you can, you can. Okay, so let's get back. So yet the demographic problems are not as pronounced as in other European countries. So we are still good to go. Another important issue affecting social policy is the level of unemployment. It skyrocketed in the early 1980s to 13%, but has come down to about 6% in the mid 1990s. The problems of unemployment has also coincided with high rates of inflation, which we've seen from the 1980s. The Conservative Party responded to these challenges, and this was by promoting job training, especially to younger people. The reason that was that high unemployment occurred mostly among untrained manual employees, which made it very hard to survive. Now, these are some key milestones that I would like to discuss in the community health services policy. You can have a look at this as well. Just a minute. Yeah, sorry, I'm just looking at something else. Okay. So in 1948, you had the community health services that were responsible for the public health arm of the local authorities. Okay, so in 1962, there was a hospital plan that emphasized the need to expand services in the community. In 1963, you have the health and welfare highlights wide variation in local authority community service provision. Then you had the Gilly report that emphasized the importance of GPs being supported by a wider primary care team and the need for closer integration between GPs and other services. In 1965, there was a report of the CBOM committee calls for better coordination between social care and other health and welfare services in the community. 1974, there was the responsibility for community health services that were being transferred to the NHS to tackle poor coordination between community and hospital services. The Area Health Authority was created, and joint planning and consultative committees were formed with local authorities. So this is how the community-centered approaches for health and well-being work. So they strengthen communities, and this is through community development, asset-based methods, and social network approaches. Sorry, this is a bit blurry. Volunteer and peer roles. So this also is a community-centered approach for health and well-being. So within the volunteer and peer roles, you have bridging roles, you have peer interventions, you have peer support, peer education and mentoring, and volunteer health roles. Collaboration and partnerships are very important in community care, centered approaches for health and well-being. So within this, you have community-based participatory researches, you have area-based initiatives, you have community engagement in planning and co-production projects. All of these are there, which are for the community, run by the community. And then the last is access to community resources. So these pathways are there for increasing participation, community hubs, and community-based um, commissioning. Okay, so going forward, so 1974, we talked about NHS. We talked about community health services being transferred to the NHS. 1987, there was promoting of better health, proposes the development of primary care teams within the GPs, working alongside, health visitors, community nurses, and other professionals. 1988 to 89, you had the Griffiths report and caring for people, highlight the fragmentation of community services and emphasize the need for collaboration between the NHS and the local government. They set out proposals for local authorities to plan and manage social care, but not necessarily to be direct providers. This leads to significant growth in independent sector provision. 1989, so following the publication of Working for Patients, community services increasingly established themselves as standalone NHS community trusts. 1997, you had the new NHS, modern, dependable, describes the aim to deliver more integrated health and social care services in the community. Primary care trusts are established, and most community health services are effectively merged into primary care trusts. Okay. Then coming towards 2000, you had the NHS plan. So there was a plan for investment, a plan to reform proposals, and redesigning primary and community services. There was the creation of 500 new one-stop primary care centers, the investment in intermediate care. The option to form care trusts is introduced, but relatively few are set up. 2006, Our Health, Our Care, Our Say sets out a wide-reaching strategy to shift care out of hospitals and expand community provision. And this included shifting resources also from the hospitals and giving them to the community. A wide variety of measures are introduced to promote integration, to improve access and strengthen prevention. 2008, there was high quality care for all. Within this, the NHS Next Stage Review recommends the separation of primary care trusts, commissioners, and provider functions, and the PCTs are directed to consider a range of different organizational models for community services. The NHS Next Stage Review is that our vision for primary and community care encourages greater pooling of resources by primary care trusts and local authorities, and also the development of new tariffs to encourage more provision of healthcare in the community. 2009, there was transforming community services that enabled new patterns of provision, which requires primary care trusts to come up with a strategy for community services and also to identify future organizational models, separating their commissioning and provider functions. 2012, you had the Health and Social Care Act that was responsible for commissioning community health services from primary care trusts to newly formed CCGs. Some services within this included public health and health visiting. They're transferred now to the local authorities. 2014, you have the NHS 5-year forward view that sets out a view of how the NHS services need to change to meet the future needs of the population. Okay, and putting patients and communities in control of their own health. And it calls for a shift in investment from acute care to primary and community services and outlines several new care models. 2015, the NHS organizations are directed to come together and to develop sustainability and transformation plans, STPs. So they're 5-year plans for health and care services in the area. 2016, 44 STPs that were decided here, they're published now. All include proposals to redesign primary care and community services, and it is often expected that this will reduce demand for hospital care. Now coming towards Sir Roy Griffiths' report, which was commissioned. So he was commissioned in 1986 by the Secretary of State to undertake a an overview of community care policy. So, this is also known as the NHS Management Inquiry. So, it was a report commissioned by the UK government in 1983, and this was to investigate the management and efficiency of the NHS. The report was authored by Sir Roy Griffith, who was given this responsibility, and he was a management consultant and former director of J. Sainsbury. So the report made a number of recommendations and this was made for improving the NHS, the management, which included the introduction of a more business-like approach to healthcare management and development of clear lines of accountability and need for greater efficiency and cost control. Report was controversial at that time. There were some critiques that argued that it placed too much emphasis on the principles of private sector and not enough on the needs of the patients. However, the report recommendations have had a lasting impact on the NHS, and there are many of its recommendations that have been implemented over the years. The report is often cited as an important document in the history of the NHS, and it has a legacy that can still be seen in the current management structures and approaches to healthcare management within the UK. So then you have the Marmot Review, very, very important. Sir Marmot, Michael Marmot, he was a public health expert and professor at the University College London. He was commissioned by the UK government. He talked about health inequalities in England. So what this said was the social determinants of health. So social, as I said, what are the social factors that influence health? So he talked about the impact of social and economic inequalities on health outcomes. So he, according to his report, and this was a well-researched report, he found that people in lower socioeconomic groups have the worst health outcomes, and they also have a shorter life expectancy. They live for lesser time, lesser number of years than those in higher socioeconomic groups. Okay, why is that? Because of poverty, because of lack of social support, etc. So, the report made a number of recommendations for reducing health inequalities. So, some of these recommendations were to reduce poverty, social exclusion, improving education and employment opportunities across the board, not just in higher socioeconomic statuses, but also in the lowest socioeconomic statuses, and promoting healthy behaviors. So, the report also called for greater investment in early years education for all, okay, regardless of their social status again, public health initiatives, and social welfare programs. So, this Marmot review, has a significant impact on public health policy in England. And with many of its recommendations being implemented over the years, the report helped to raise awareness of social determinants of health and the need for a more holistic approach to healthcare that addresses the root causes of all these health inequalities. This report, when it was published, it also influenced the development of Health and Social Care Act, which happened in 2012. And this was aimed to improve health outcomes and to reduce health inequalities in England. Then you have the NHS, the National Health Services. This provides comprehensive healthcare throughout England. How is it managed? We'll talk a bit about what are the main fundings and what happens within the NHS. So here, the NHS provides medical care through a three-tier system. Okay, so what is this three-tier system? There's primary care, hospitals, and community healthcare. So this is how it makes a tripartite or three-layered care. So the main element in the primary care, so you have GPs or family doctors who provide preventive and curative care, and they refer the patient if they're needed to hospital and specialist services. All consultants with a GP under the NHS are free. Other major types of primary care are dentistry and pharmaceutical ophthalmic services for the eyes. These are the only services of the NHS that are charged. Okay, so under 16, there's no charges. However, there has been changes where you have to there are charges for dentistry for under 16 as well. Past retirement is free, and people with low incomes are usually exempt. Everyone else must pay charges that are below the full cost of the service included. So under the Development or Department of Health in England, There are 4 regional health directors who oversee health area authorities, and they have their major responsibility to run hospital services. So, overseeing the health authorities in Scotland, Wales, and Northern Ireland is the responsibility of their respective parliament or assembly. Hospitals, they take up more than two-thirds of the NHS budget because obviously they need more crucial stuff to be there. All hospital treatment under the NHS is free, including consultations with doctors, nursing, drugs, and intensive care, whatever the type of medical problem and however long the hospital stay. Hospital doctors are paid a salary rather than a fee for service, but they can combine salaried work for the NHS within a private practice. Community health services have 3 functions. So, this is to provide preventive health services, to act as liaison with local government, and especially over matters of public health. And the third is to cooperate with local government. And this is in regards to personal social service departments to enable health and personal care to be handled together whenever possible. So there's some contemporary issues within. So this video, mm, we I'm sharing the top things that have we have in the video that I had shown you earlier as well. What are the contemporary issues in healthcare? So an aging population, a growing population, evolving healthcare needs, like you have obesity, you have diabetes, you have antibiotic resistance. Medical advancements save lots of lives every year, but there are a lot of cost that has to be covered because of these medical advancements. The top line facts on big health issues in health and social care: you have the nation's health, the NHS performance and waiting times, health and social care funding, and health and social care workforce. So, why communities matter? Just give me a minute. So why do communities matter? So communities matter because within the communities you have preventive care that you can utilize. Okay. So there's a lot of patients who remain in the communities who do not access hospital care. So many of these are there in the communities and they have a vital contribution to make within the health and well-being. They build control and resilience, help buffer against disease and influence, health related behavior, and management of long term conditions. So whenever you keep people within you keep people within your let's say plans, you work much better. So a partnership works much better compared to working as on your own. So why communities matter? So it is because placing communities at the heart of public health can reduce health inequalities. It can engage, so you empower people to have a greater say in their lives and in their health, create connected, resilient, more cohesive communities, and you engage those most at risk of poor health. So when you involve and empower people in the local communities, especially who are disadvantaged, there is a strength. This gives you a strength, okay, for both promoting health and reducing health inequalities. So the according to the NICE guidelines, it is very important for community engagement to happen, and this is as a strategy for health improvement, particularly as it leads to services that better meet the community members' needs. Being connected matters for your health. So loneliness and social isolation, they're damaging to our health both mentally and physically. Being cut off from social interaction affects people no matter what age they belong to. Um, you have the Community Life Survey 2016 to 17 that found that 5% of adults in England reported they felt lonely often or always, which has remained unchanged since 2013. Most but not all people have someone to rely on, and over half, like let's say 54%, stated that they felt lonely hardly ever or never. Okay. Um, and health inequalities persist, and many people experience the effects of social exclusion or lack of social support. You have the Marmot review that I have talked about, and do have a look at that. that gives guidance on how to reduce these inequalities. Now we talk about building social capital with community-centered approaches. So this edition of Health Matters, this focuses on, this publication focuses on the use of community-centered approaches. This is to enhance individual and community capabilities, higher, create healthier places and reduce health inequalities. Community-centered approaches, they're not just community-based, but also mobilize assets, within the community, prompting equity and increasing people's control over their health and lives. Most local authorities, they are embracing community-centered ways of working, but the challenge that many are now seeking to achieve is the scaling up of a whole system, community-centered and asset-based approach that is built bottom-up from the diversity of grassroots community organizations and members. So what this community-centered approach does, the family of community-centered approaches, it strengthens communities, it introduces volunteer and peer roles, collaborates and partnerships, collaboration and partnership is produced, and access to communities' resources is introduced, and it has a positive impact on your health and well-being. Now we are going towards the last bits of our today's discussion. So we are explaining the social issues in contemporary society that have an impact on your health. We had talked a bit about it, but now we'll talk in detail. So health inequalities, so they're significantly impacting health. Um, so these inequalities, they are linked to social factors like poverty, education, and employment. Like people living in poverty areas are more likely to experience poor health outcomes than those who are living in less poverty area, more affluent areas. Mental health is increasingly important in an issue that has great importance in the UK, with many people suffering mental health problems at some point in their lives. There is a significant stigma around mental health, and this can prevent people from seeking help when they need it the most. Aging population, we've talked about this. The older population is likely to have more complex health needs, and they require more care from the NHS than compared to younger people. Obesity, a major public health issue in the UK, and it's found that around two-thirds of adults and one-third of children being overweight or obese are found in the UK. So obesity is linked to a wide range. You have diabetes, you have cancers, you have heart diseases. Then comes social isolation again, loneliness, and it leads to poor mental health and has a negative impact on health. These issues have a significant impact on the UK healthcare system. There's increased demand for services and new need for new approaches to healthcare delivery. Addressing these social issues will be crucial for improving health outcomes and ensuring the sustainability of healthcare system in the future. Um, yeah, we've talked about this. And that's about it. Any questions? These are the references from today's session. Please have a look at these. These will be shared with you on Moodle as well. You can go and further read about these bits to improve your understanding. I'll stop sharing here. I'll actually stop recording the session. Please let me know if you have any questions for me. Stop sharing the slides. Stop recording.